Good morning, friends, and thanks, Satya, for asking me to participate in this course. Actually, the course is titled as ACIOL Revisited. So, for me, I have really believed in the efficiency of ACIOLs if properly selected, proper circumstances. So, for me, it is not exactly revisited, but I'm going to highlight, some of the points which have to be kept in the mind when you use this lens, or some of the situations where you should not be using this lens. Now, some time back we edited a book on posterior capsular dent, and there was a chapter, big chapter on ACIL by Dr. Biro from Hungary. So if you want to see all the detailed analysis, meta-analysis, and the various comparison, this thing, you can go through this particular book. So now there are certain prerequisites for ACIL implantation. Many surgeons actually who talk against this particular lens, I have seen their own cases, and either directly or over the conferences. It is basically the cataract surgery complication which has not been managed well, and now the blame has been shifted to ACI. So we need to know what are the prerequisites, and only in if these conditions are satisfied, AC lens should be used, and they'll give good results. So patient should anatomically have a normal anterior chamber angle. If peripheral anti-sonic is present, it should be present in less than 2 clock hours in either meridian. The anterior chamber depth has to be normal. Good standard normal iris architecture is one of the prerequisites. Good corneal endothelial health. There has to be patent and generous peripheral iridectomy once you implant the ACIL. Usually prefer to use these lenses in patients who are of this senior age, elderly patients, senior age group. And you must understand the intraocular lens, AC lens design, and know how to handle it properly. So the selection of, there are certain selection criteria. Say, for example, what should be the power of the AC lens and what should be the sizing. Now, as regards power, when you calculate the IL power during your whatever optical biometry that you do, you can use the A constant for the ACIL. In case it is a certain decision and you have not really calculated the ACIL, there is one rule of thumb. It was published in the Survey of Ophthalmology in 2005. You reduce 3 diopter from the calculated in the back PCL power. But I would suggest that you use the A constant in your lens calculation formula. Choosing the correct size is very important. So whenever we do optical biometry, you always get the horizontal white to white diameter. And we need to use a lens which is 1 millimeter more than the horizontal white to white corneal diameter. So this is a must. So now the standard AC lenses which we have in the inventory are to 12.5 millimeters. So if you're dealing with a very small cornea or a large eye, in that case you need to ask the company to provide you with additional inventory in case you have PC rent and you have no other options, and this is the backup lens, which if not used can always be returned to the company. So there are hazards with an oversized ACIL, and I'll be showing you some of the pictures, anti-segment images, ovalization of the pupil during surgery. So that time itself we'll know that it is an oversized AC lens and it has to be taken out. And in the long run, ocular discomfort and angle erosion can always happen. Undersized ACIL, there will be excessive mobility, and if you have not expanded it, there will be endothelial compromise. The UGG kind of syndrome, cystoid macular edema may be more common. So this is about the AC handle. When you take out the AC lens from the box, as you pick it up with the McPherson forceps, the AC lenses are vaulted anteriorly. So, the right side should face the cornea because that is where the vaulting is. And so basically you want the lens to be vaulted anteriorly. And many people actually they flip it, they're thinking that, the lens has to be vaulted away from the corneal endothelium. And then it is, since it is vaulted posteriorly, it is tightly attached to the iris, or if there's antivitreous phase, and postoperatively you can always get secondary glaucoma and all sorts of complications. So this is the common thing. You must inspect the lens. And then this is a very old technique. I have not used an ACIL for quite some time. So this is actually, I had a complication here, superior phaco, so I went for the temporal approach, made a scleral tunnel. And then, the IOL was properly sized. And the lenses should always be kept horizontally. So that is, in case the lens is slightly undersized, so the propeller effect will be much less if you have kept the lens in the horizontal meridian. Some people say that the AC lens should not be dialed. I think it is not so, because the lens is not resting on the angle it is resting on the ciliary, but it is on the scleral spar. So if you have placed the lens properly, the gentle handle rotation after compress the haptic, make sure that the haptic which is in a position of the angle is pulled away from it, and then rotate the nucleus and keep it in the right axis. Now these are some of the problems that an improperly selected ACIL can give rise to. So recently there was a discussion in the WhatsApp group, and then some surgeon, senior surgeon commented that he misses the Pannu lens. Pannu lens was a very versatile lens. It could be kept in the anterior chamber, it could be kept in the posterior chamber. But these three-piece design lenses should, no lenses meant for the posterior chamber should be kept in the anterior chamber. Now, so this is actually some of the oversized intraocular lenses. You can see how much, I'm not getting the, yeah. You can see, how close the haptic is from the optic margin in all these cases. Okay, so this is a particular case where the patient had the haptic coming in the section. And so I just actually wanted to rotate the lens, but then I realized that the haptic was very densely adherent to the scleral tunnel. It was an SICS done elsewhere. And now, of course, I don't see many complications because surgical skills with SICS has grown tremendously. People are doing extremely well. So I could not really mobilize the lens. So here, initially I didn't want to extend the incision, because if you extend the incision, there is always a fistula. So you have to, closing this thing will be quite difficult. So when I went, put the lens behind into the anterior chamber, and made a temporal tunnel, scleral tunnel, and then explanted the lens. Then I realized that there is adequate support for a PC lens. When I did posterior synucleolysis and iris retraction, then injecting visco behind the iris, so there's adequate posterior capsule. So I used a posterior chamber lens in the ciliary sulcus, as you see here. So many a time, when you have a PC lens, you get panicky and you just put an AC lens, or you take a knee-jerk reaction and do things which should not be done. So it is not a crime to keep the patient aphakic. You should have a prior discussion with the patient and say that there may be a rare situation where, in the best interest of your eventual outcome, I'll leave you aphakic, and once the eye heals a little bit, I most probably will be able to do a better job than if I, put a AC lens straight away. So this was, again, there are, these are post-operative pictures. The patient had done quite well. So this is again an oversized lens. So I expanded the oversized lens and used a proper lens, properly sized lens. So basically the guidelines should be followed. You have to be aware of some of the surgical guidelines which I have discussed here. And adequate anterior vitrectomy, anterior segment reconstruction is mandatory. And it has to be lenses to properly sized, and I've given you the guidelines. These multiplex lenses are very good. They can be compressed. So it is not like all one size fits all. So if you have a 12.5 millimeter ACL in the inventory, I think it should do well. And so these are good. So now I have reviewed many of the meta-analysis and of the different types of secondary IOLs in complex situations. And most of the conclusions used to be that it all depends upon the surgeon. There is no definite superiority of one technique over the other. So this was recently, just recently published in JCRS. It is a review and a meta-analysis which showed, actually it started out with 1, 3, 5, 6 articles, and then it could review only 15 articles. And the conclusions I'm just showing you up, say overall complication rate included, which was non-significantly lower in the iris fixation category. So there is some justification of using iris fixation lens in complex situations. Transient corneal edema, which is the most common complication in AC placement, and complications like vitreous hemorrhage, eye disintegration, dislocation are more commonly seen in scleral fixated intraocular lenses. Cystoid macular edema was meaningful higher after various eye fixation methods. So conclusions: risks associated with particular techniques should be taken into account in preoperative counseling and planning post-operative treatment. So with all these precautions, I think in selected cases, ACIL still gives us good results. Thank you very much for your attention.
Thank you, sir. By the time Dr. Deepak gets ready, an excellent talk on ACIOLs. In fact, I have seen many ACIOLs, well-done ACIOLs still doing very well. What is your opinion? Still you think, there's a role for ACIOLs now also, and because it's easier and probably like maybe, yes.
See, if it is a very challenging phaco situation, before I get a PC rent, I would have anticipated problems, so I would convert it into scleral tunnel and do an SICS and put a PC lens. Okay, but AC lens, as I told you, I have not used for last maybe 3 or 4 years. There are certain situations where I have used in the past are very uncooperative patient. When we had a PC rent, and you cannot take the patient back to the operating table for the second surgery, because AC lens is much faster. So, only I think that is the main indication where you still may end up using an AC lens. Otherwise, I would not prefer to use an AC lens. But if you're using, then you have to follow the proper technique.
Sir, one question, yes, sir. The different sized ACLs, sir, are they available still now, or how do we order?
See, my inventory has, I get it from Aurolab, 12.5, and in case I require so inventory is always there, I pay for it for 12.5. But if it is high-sized or low-sized AC lens, for example, earlier they used to have the inventory, but now they don't have. So, for example, if it is, earlier they used to have 12, 12.5, and 13.
Okay.
So, you have to order, then, so they make it specifically.
So they'll make it specifically.
Yeah.
Ready stock that might not
Yeah,
be available.
yeah.
Okay.
But as I told you, I mean, I keep this as a standby in
Yes,
case something, because I cannot say that because I didn't have the lens, so I'm keeping a fake.
Yes, yes, yes.
If I'm keeping the FA kick, it is planned.
Yes, sir.
That's why I'm keeping the patient FA kick.
Thank you, sir.
Now, the biggest problem with ACIOLs is not the ACIOL. It is the problem with the surgeon who has mismanaged the phacoemulsification, done a very, very, what should I say, rough phaco, and or corneal endothelium is already gone. I have seen many such surgeons, the post-op patients, when I was at Aravind, and subsequently I see the videos when AC lens have been implanted. So it is, I don't think you can attribute the blame to ACIL. It has to be, the surgery plus the ACIL. But you're right, if the AC count is less than 1500, I'll be a little reluctant to use an AC lens. In that case, I'd go for a scleral fixation. That is a good point. But see, for example, maybe so these surgeons are biased on the podium against AC lenses because they have had a lot of problems in their own hands. On the other hand, when I was at Aravind, I have taken a lot of scleral fixation, the iris claw lenses, Daljit Singh, more than 50 or 60. So maybe I'm not biased against these lenses that it is associated. All those patients had corneal edema. So I would prefer to use AC lens, but I know that iris claw lenses, Deepak also will show, and Satya also shows, they do extremely well.
Dilated pupil, sometimes we don't constrict, or the pupil doesn't constrict with intracameral myotics. We sometimes find that after the lens implantation, next post-operative day, the pupil will come down and there will be some iris tucking, iris root tucking.
Yeah.
So is there a way to manage that complication?
No, I'll be using, intracameral pilocarpine that is routinely stocked in my this thing. So if it doesn't really come down, I use the Sinskey hook to stroke the iris. It comes to about 4 or 5 millimeters. So once I know that haptics, it is resting on the scleral spar, and I'm rotating and there's no deformity of the pupil, I leave it assured. But you're right. But if in spite of all that, if I see the pupil is peaked, then I know that it is an oversized intraocular lens or there is an iris tuck that has happened.
I think the most common reason for blame of the ACIOL is the surgeons would not do a proper anti-vitrectomy. So it is, as sir was telling, it is lack of doing the proper vitreous management at that stage, and then we end up with the complication and then blame it on the AC lens.
Correct.
If you done a perfectly done anti-vitrectomy, and all lenses would work equally well.
You're right. AC lens is a very good excuse
because
for the
automated
surgeon.
anti-vitrectomy concept was not there 10-15 years back, and they never used to identify vitreous and just push the lens and blame it on the lens rather than the other things.
That's right.
Vitreous management was the most the most common reason why the corneas used to go blank or uveitis or all those things.
No, just to cover up one's mistakes, blame it on